Good afternoon, good morning and good evening wherever you are, and welcome to this, the fourth of 6 plenary sessions of the HSRUK 2020 conference. My name is Naomi Fulop. I'm Professor of Healthcare Organisation and Management at UCL and member of the board of HSRUK. And I'm delighted to be chairing this session on how research can shape mental health policy and practice. It turns out that moving to a virtual format, as we have for the first time this year, has all sorts of unintended positive consequences, not least that we have colleagues joining us from all over the world, over 40 countries, and we've increased conference registrations tenfold. Welcome everyone. First, a number of thank yous to the Health Foundation and the Nuffield Trust for their support for this conference and to HSRUK. And to the conference organisers who have done such a fabulous job in just a few months putting together this virtual feast of health service research for us all. In addition to the live plenaries, there are a host of recorded presentations, workshop sessions and posters to view on the conference website, which have already been viewed thousands of times. And if you haven't already, I hope you'll take the opportunity to have a look. So now to this plenary. We've had quite a lot of discussion already at this conference on the ways research can shape policy and practice, both the pleasures and the pitfalls. Yesterday, we heard from Joseph Figueres and Trish Greenhalgh on the role evidence has played during the pandemic, and from Rob Briner and Luella Vaughan on whether and how evidence matters to managers and the NHS. So thinking about mental health, in the UK, it's about 1/4 of the total burden of disease, and the economic costs of mental ill health are estimated to be approximately £1 billion per annum. For the past 10 years, there's been a commitment to give parity of esteem to mental health and physical health, but progress has been slow. Mental health professionals and researchers are now drawing our attention to the impact on mental health of the pandemic, including through the closure of schools, the isolation of people shielding, and the increasing economic uncertainties for millions of people. Yesterday, I was struck by Joseph Figueres' use of lessons from Stoicism for those of us who are trying to influence policy and practice with research evidence. He brought to our attention these 3 lessons. First, humility and willing acceptance, particularly that research evidence is only one factor in policy making. And we've seen that play out in how different countries have responded to the pandemic. The second lesson is around objective and rigorous judgment, being transparent about the limitations of our evidence and self-awareness of cognitive biases and values we bring to bear. And finally, despite the first 2, courage and unselfish action through pragmatic action. So we couldn't have found 2 more appropriate and excellent speakers to reflect on these lessons in relation to mental health policy and practice. They each have years of experience in being centrally involved in bringing research evidence to bear on mental health policy. First, we have Sonia Johnson, Professor of Social and Community Psychiatry, University College London, and Director of the NIHR Mental Health Policy Research Unit. Sonia will be followed by David Clark, who's Professor and Chair of Experimental Psychology at the University of Oxford and NHS England's National Clinical and Informatics Advisor for the Improving Access to Psychological Therapies programme known as IAPT. And David's going to be talking about IAPT in his presentation. We will run the 2 presentations one after the other and then have time for question and discussion. We will finish at 3 p.m. British Summer Time. I'll now take you through how to post a question, which I hope you will take that opportunity to do. You select the Q&A option, which is at the bottom of your Zoom window, and you can paste a question anytime during the session. I really encourage you to use the upvote option so that I and moderators can see which are the most popular questions, and we'll try and get through as many as we can. I'll now hand over to Sonia for the first presentation. Thank you.
Thank you very much, Naomi, for your introduction, and thank you very much for the invitation to sort of be at the HSR conference in this novel form this year. And hello, everyone, wherever you are in the world. So I'm going to talk briefly this afternoon about some experiences I've had of trying to shape mental health policy and practice through two different major programs of research. I'm going to say a bit about the barriers as I found them to influencing policy and practice, and about what might help with those barriers. I did think maybe I should mug up a few implementation theories before giving this talk, preferably ones with rather long names. But actually, I think what I can mainly bring to this is my experience of trying to operate in this sphere. And so that's what I'm going to focus on in this talk. So the first of the two programs of research I'm going to tell you about is one that's been going on in my division at UCL Division of Psychiatry, where I work for almost 20 years now. We've been working on trying to establish the effectiveness, the cost effectiveness, the impact on service users and clinicians of various types of alternative to acute admission. What you see in the picture is one of the oldest of such alternatives, Soteria House, which is a crisis house in California established in the 60s. We've been looking at crisis houses, at 24-hour alternatives to admission on community premises, also very much at crisis teams, which are the 24-hour teams providing intensive home treatment that have been a staple of UK mental health services for many years, and also at day services that provide acute care. And we've used a variety of methods to do this work. I'm going to tell you a little bit about the most substantial of the studies and the one that's brought most attention, which is an NIHR program called the CORE program, where we carried out two studies. One was a large trial, I think my only data paper ever in the actual Lancet. Usually mental health service researchers have to publish in perhaps slightly humbler places. And we found that self-management intervention delivered by peer support workers at the point of discharge from a crisis team successfully prevented some repeat admissions to acute care. And the second study within the same program focused on trying to optimize the crisis team model by developing a fidelity scale to reflect good practice in such teams, and a toolkit for trying to improve fidelity, which we then tested through a cluster randomized trial, which was a bit equivocal, but indicated potential benefits for admission rates of this approach to improving good practice in crisis teams. So some substantial findings from this work. What impacts have we been able to see? Well, sometimes it's a bit hard to know what exactly is your impact, but certainly as far as we can tell from what policymakers tell us from citations in policy documents, our work has supported the inclusion of this crisis team model in successive sets of policy guidance and NICE guidelines. We've also probably helped stimulate a growth in the crisis house model. And I think our research has reassured people that not only do these models result in very good user satisfaction, but they also seem to be capable of treating at least some of the people who present with relatively severe mental health problems. Our crisis team fidelity scale has been adopted by NHS England as a significant part of its crisis care policy, And our preliminary research, together with a bit of health economic wizardry, was used to apparently to help get funding for their large priority program on crisis care. And we've also seen the adoption of the crisis team model and in several European countries and its inclusion in policy. This successful peer-supported self-management program, we were very pleased to see that at least some of the study sites have now reinstated it as an ongoing part of their service provision, including the Camden Mislington Trust, where I work. So this is an example of, we didn't have any connections with policymakers really when we started this. We were researchers initiating this program of work. So how did we try and get it into, what helped us get it into policy and shape practice as far as it has done? Well, it's pretty opportunistic rather than systematic or theory driven as far as we're concerned. We've always tried to be proactive in just getting in touch with people, proactive in contacting key staff at places like NHS England and telling them about our findings. We find it pays to be helpful and to try and form relationships with key people. So I've certainly spent quite a bit of time explaining to people in policy circles who've maybe just come into post what the crisis care landscape looks like in the UK and what we know about it so far. And I think that's been fruitful. I think one needs to be patient. It can take a long time to see impacts for it to be the moment when work can get taken up. I think you have to live with some uncertainty as to what it is that's actually having an influence. Unless you are very clearly the person who's invented a treatment, you may not know whether your work is actually promoting it. And as Naomi's already mentioned, there are many pressures to which policymakers have to respond, the ideas that politicians bring from various sources, professional bodies lobbying, members of the public and the voluntary sector can be influential. You have to understand when you're trying to have an influence on policy that research isn't the only thing that is going to be influential. In terms of practice, I think there's some service managers who are much more interested in innovation than others. Making links with them can be very fruitful. And I'm also a strong advocate of hanging around on Twitter. Even now that I have a policy role and a link to the DH, I would say that that's quite often where I have conversations with policymakers that are helpful. And another thing that has helped certainly is a willingness to participate in things like guideline development, which again can be a good way of making links, of making sure that evidence that we and others have developed finds its way into policy. So a second experience I've had, one of a few, but has been more recently, of a more formal relationship with policymakers. And this has been in the Mental Health Policy Research Unit funded by the NIHR, which was commissioned for 5 years in the first place, from 2017, with a brief to deliver evidence relatively rapidly to inform policy and based on a programme agreed with the Department of Health and Social Care and the arm's length bodies. And we're not resourced to do big primary data collection, so it's been about various types of reviews, economic modelling, some focused qualitative data collection, some analyses of data that's already available. An example of what we've done has been, first major programme was on providing evidence to inform the independent review of the Mental Health Act, which appeared at the end of 2018, sorry. And this is a list of the work we did. As you see, it's mainly reviews of various types, but we also did some analysis of routine data and a study collating and analysing international data on variations in Mental Health Act use. What did we come up with that was influential? Well, these are some key findings that were cited in the review and that appeared to be an influence on the conclusions reached, although we could see that there were many other consultations and sources of influence on what emerged eventually. So we found that compulsory community treatment didn't seem to prevent compulsory admissions, that advanced crisis plans potentially do prevent them, but can be hard to implement sometimes. We found that service users and carers place great value on good quality explanations of processes and often don't get them, and that applies even when compulsory admission does occur. And we confirmed through our evidence synthesis a number of relationships with demographic and service related factors that create a risk of future compulsory admission. We also found many things that we don't so far know. There's a great deal missing in the evidence base. So what worked in this more, and what's working now in this more formal relationship with policymakers? Well, I would say we run round after them a fair amount. They often have a great deal in their minds apart from arranging to talk to people who are going to produce evidence. I think persistence in trying to make relationships, trying to have conversations about what's going to be useful. Evidence gets used when it fits with current policy programs and current priorities. People can wait months, but rarely years for evidence. So obviously anything that draws on existing data, existing evidence is helpful. We found that policymakers place quite a high value on stakeholder input, and we work with a very lively and active lived experience group that's involved in multiple ways in our research, including things like data collection and analysis, and that produces a commentary like the one I've copied in here, which is from our current COVID work on each of the papers that we publish. We've also held stakeholder events to which we invite the public and policymakers and really allow policymakers to hear from people they might not directly meet so often otherwise. We've produced briefings that we aim to be succinct and accessible, but actually also not oversimplified. We've found that people value understanding what the strengths of the evidence are, understanding what the limitations actually are as well. It's important to form relationships and also important to get to know the people who influence policymakers. So we have a very helpful partnership with the Centre for Mental Health, which has long experience and many links in working with the DH and the arm's length bodies. We're still hanging around on Twitter and finding out a lot of valuable things, and also finding that that's a place in which we can actually have an influence and get in touch with people who are important. A link with the Mental Health, who's a very influential blogger and social media influencer in the sphere of mental health policy and practice, has also been extremely valuable to us. What are the limitations? Well, there are many. I would say some are that research interventions, as in many spheres, tend to come to an end when studies do, even if the studies show a positive result. Clinical practice in mental health is quite hard to change, although perhaps one might say that a bit less, having seen what's happened in the last few months. You may come up with something exciting that doesn't fit into a current policy programme. It then becomes quite a lot harder for it to have an influence. In research, for very good reasons, we think that negative research findings are just as important as positive findings, but certainly it's rather harder to get them to influence practice and policy and to get interest really in the same way. And also must be said that policy and innovations are to varying degrees based on accurate readings of the research. And I want to finish by showing you, actually, I think this is the only paper I've published that's directly about the relationship between evidence and policy. So I'm keen to show you this work. So I and some colleagues at UCL, including a couple of very able MSc students, published this paper last year in which our MSc students went through 10 policy documents and looked at the citations in those documents to research and whether they were accurate and whether by following the citations in the policy documents you actually could get straight to the research finding. And as you'll see, there were quite some limitations. So a bit over half were fully accurate. What the policy document said was just what the paper had said. And a bit over half could be straightforwardly reached from the policy document. So I look forward to your questions. Thank you very much for listening. Do follow me, the Policy Research Unit, and the Loneliness Network that I lead on Twitter. And just to root this in geography a bit more, that's a view from Forest Hill in southeast London. I'm speaking to you from there, and thank you for listening wherever you are in the world. Thanks very much. I'm now handing over to David Clark, who's going to talk about IAPT.
Great, thank you very much, Sonia. And it's a real pleasure to join you all today, wherever you are in the world, and to give you another example of research influencing practice, this time from the English Improving Access to Psychological Therapies, or IAPT program. IAPT was created to solve a problem, really to do with research not being implemented. So over the last 30 years or so, really considerable progress has been made in developing effective psychological therapies for a range of mental health problems. And that progress has been recognized by NICE, which now recommends certain psychological therapies as the first choice interventions for depression, for all the anxiety-related disorders, including PTSD, and also for the eating disorders. So that's good news. But the problem is that in most countries, the majority of the public don't benefit from those advances. And that's not because they don't want to. So there are over 30 surveys of the public asking if you had a choice between an evidence-based medication and an evidence-based psychological therapy, which would you prefer? And obviously some people say, I would really like the medication. But in a ratio of 3 to 1, people say they prefer psychological treatment. But there is no country in the world where the public gets what it wants. Nowhere where psychological therapies are more available than medication. And in the UK, before the program I'm about to describe started back in 2007, the situation was particularly dire. It was estimated that no more than 5% of people with depression or anxiety-related problems were getting an evidence-based psychological therapy. So IAPT is an attempt to change that by vastly increasing the availability of effective, and by that we mean NICE recommended, psychological treatments for depression and all the anxiety disorders. And it does that by training a new cohort of psychological therapists using national training curricula, because with psychological therapies, you really have to deliver them well to get the good results. And you only sort of pass the training course if you demonstrate the relevant skills with videotapes of your therapy sessions. And then once people are trained, to employ them in new services, about 8,000 people so far, and then critically to try and measure and report the clinical outcomes of every single patient who has a course of treatment. And really sort of full public transparency to see whether the investment has really delivered the public benefits that were promised. The initiative was based on very sound combined economic and clinical arguments. And what were they? Well, I guess there are 3 big strands to it. The first is to point out that not treating anxiety and depression is very costly to society. It depresses our gross domestic product by about 4 percentage points, which was a lot pre-COVID days. That's partly because when people are in work but are depressed or anxious, their mind is often somewhere else, and so they're less productive, and that means you have to employ more people for the same productivity in a company. That's what we call presenteeism. But also, of course, many people aren't able to stay in work because of their mental health problems. But secondly, of course, there was evidence that you can, in routine services, get the sort of outcomes that you would get in the sort of gold standard randomized control trials, because it is possible to train therapists in routine services to a high level of competence. And also, it is possible in routine services to monitor the outcomes of everyone, as long as you give measures each time someone's seen, so that if they drop out of therapy early, you still have a clinical endpoint. And really, the first clear demonstration of both of those points came out of a tragedy, the Omar bomb. There's a picture of this high street in Omar after the bomb, and setting up a community psychological therapy service to treat PTSD following the bomb, which really demonstrated these 2 points. The last point, an economic one, is to say that when times are hard, it's economic madness not to do something like this, because actually it's got minimal net cost. In fact, it saves more money than it costs, because effective treatment of depression and anxiety reduces many other physical healthcare costs. So there's a big saving in the NHS, but also, of course, has broader benefits to society in terms of productivity, increased tax revenues as people get back into work. And those arguments are outlined in great detail, if you'd like to look at them, in the book that Richard Layard and I wrote called Thrive, The Power of Psychological Therapies. So that's the broad argument. How was it advanced? Well, it started actually by going right to the top. So we sent a short note to the Prime Minister at the time, Tony Blair. He was interested and set up a seminar in the Cabinet Office. And Richard Layard, who is a very distinguished economist, and you see him here in this blue shirt, and I were given 15 minutes each to outline, in my case, the clinical argument, and Richard's the economic argument, and then had several hours of grueling Q&A. But that led to a commitment from the government that if they got re-elected in the election coming up in May of that year, they would start implementing something like IAPT. They did get re-elected. They understandably said, this is a big project. Can you first do some pilot studies and show that you can get it to work? And so they funded 2 pilots, one in Doncaster and one in Newham, led by David Richards and Ben Wright. And those 2 pilot projects did show that you could get the outcomes that were promised, both clinical and employment. And at the same time, there was a continuation of public lobbying now. We wrote something called the Depression Report, a pamphlet that outlined the arguments and came out in the Observer. The mental health charities got involved and they wrote their own document called We Need to Talk. And that coalition between the clinical researchers and the mental health charities was very important. Of course, lobbying has to continue. So as the IAPT program has progressed, we have continued lobbying, and you see a photograph here of Richard and I giving David Cameron a copy of Thrive in 2015, when we were hoping his government would further expand the program. So what have been the sort of big policy milestones? Well, the national launch of the program was in 2007 by Alan Johnson, with some very specific commitments, one of which was to greatly reduce waiting times for psychological therapies from the scandalous 18 months that it was at the time down to a few weeks, and also an outcome target saying that, as we'd expect from the research, you should be able to get at least 50% of people to recover with treatment and more to have worthwhile benefits. The program has subsequently delivered much of what it committed to, and so it has thankfully been expanded, firstly by the coalition in 2011, and then twice by the current administration. So what has it achieved so far? Well, it's a work in progress, so more has to be done. But we now do have IAPT services in every area of the country, every CCG, and around about 1.1 million people are seen each year. It has a sort of triage function, so many people who are seen, they might just require advice or signposting, say to debt counselling. But for those people who require a course of treatment, they're offered that. That's about 604,000 a year at the moment. And most of the services offer a choice of therapies, certainly for depression, because NICE recommends several therapies. And the average waiting time has come down to just a few weeks. It's on average 20 days. And patient satisfaction ratings are high. For assessment, about 96% satisfaction, and for getting the right help for your problem, 93%. The outcomes now are in line with what the government committed. So 52% of everyone who's seen at least twice gets to strict recovery criteria, and 68% shows substantial improvement. But as you can see from this graph, it took some time to get there. So there's the red target, 50% recovery. At the start of the program, it was 40% or lower, and it took several years to get to the target, but it's been reliably above that for the last 4 years. So how did it achieve that? Well, the answer really is research. So studying the variability in outcomes between the different IAPT services, there are around about 200 of them, understanding what it is that makes one service perform very well, and then feeding that information back into the system. So what are some of the discoveries that have come from that? Well, they're all summarized in a manual that you can download free from the NHS England website, the IAPT manual, and I'll leave you to have a look at that because there's lots of things in it. But I'll just highlight a few points. So this is a paper we published recently in Lancet, where we looked at what are the sort of factors to do with how a service is organized, which are associated with better or worse outcomes. And each of these things listed here are independent predictors. So those services that are really good at identifying what the key problem is that they're going to treat right at the start of treatment get much better outcomes. There's a sort of dose response effect. Those services that give a higher average number of sessions get better outcomes. And how long you wait for therapy is also important. So, and you can see that on this graph here. This is the average waiting time for treatment in a service and how likely people are to improve in that service. And for the first 6 weeks, it doesn't really matter how long you wait. But if a service on average makes you wait longer than 6 weeks, then the outcomes are less good for that service. So this has changed policy. And now we encourage all services to get as many people as possible seen within the first 6 weeks. There was another finding there, which was services in more socially deprived areas tend to have slightly less good outcomes. But we found that isn't an inevitable thing. If you make sure you get all these other quality features of a service right, then you can do very well in socially deprived areas. And this is shown here. We have 2 areas, Windsor, where the Queen's castle is, and it's not at all the deprived area, and then a very deprived area next to it, Slough. They are both served by one very high quality IAPT service, and they both get recovery rates well above the national target, and if anything, Slough does better. So it is possible to finesse the effects of social deprivation as long as you don't deprive people of a quality psychological therapy service. So where is the program going in the future? Well, we are pleased with the outcomes that it's achieved, and for that reason, the government has committed to expanding it considerably more. So by 2024, the aim would be it would see about 1.9 million people a year rather than the 1.1 that is now. And that development isn't just an expansion of numbers. We want to bring together the physical and mental health care in what we call integrated IAPT. So if you have depression and diabetes, you'll get all of your care in the same location and coordinated. Of course, caring for the well-being of our patients is central to IAPT, but it's also important to care for the well-being of your staff. And so we're developing much more staff well-being initiatives. and making much greater use of digital platforms to deliver therapy. Of course, very common now in lockdown with video conferenced therapy sessions, as well as video conferenced health service research programs, but also virtual reality and internet programs. So what are some of the lessons that I feel I've learned from the privilege of being involved in this program? Well, I think it really helps if your research ends up in clinical guidelines. It's easier for policymakers to follow implementation if they feel it's supported by clinical guidelines, particularly the relatively impartial ones not linked to any professional organization, as we have in NICE in England. If your research is about treatment outcomes, then it's really important that when you get some preliminary funding, you step up to the plate and agree to measure the outcomes in the real world, show that you can deliver what you would promise from the research, and ideally real public transparency so everyone can see that. So other members of the public will lobby for further expansion if they know it's worthwhile. As you saw in this case, it's not just showing that something is clinically effective. We all have strapped economies economically and health services with big challenges economically. So it's very important to pay attention to the economics of the argument as well as the clinical one. And in all areas of life, but particularly trying to influence policy, it's important to make friends. And in this context, at least, there are two types of friends that are particularly valued. One is economists, and the other, of course, is politicians. And in my experience, they are both very normal, very helpful people, and it's well worth reaching out to both and helping them as much as possible. With psychological treatments, they don't deliver the goods unless you deliver them well, and that means you need a good training program, and you need to help therapists if you want them to collect outcome data by giving them good IT systems to support outcome monitoring, to give them good quality regular supervision, and to make it easy for patients to input their data, often from a mobile phone. A lot of the ideas in IAPT at the time, particularly this complete public transparency about outcomes, were quite revolutionary at the time it started. And there were many members of my own profession who were not keen on that full public transparency. And so we decided that the best way to progress is not to ask everyone to do something that they don't necessarily want to do, but rather to have a principle of opting into the revolution. So you don't use IAPT to replace existing services. There's vast undertreatment of mental health. So it's an extra provision on top of the existing provision. And you allow people who are interested in working this way to opt in to the revolution. And that ensured that the services were able to get good results from the start. But what is also critical is the quality of the clinical leadership you have in any implementation program. If you're collecting and reporting data, it has to be done with the right tone and the right leadership. It has to be done because we're all interested in learning from it, not because it's some sort of awkward performance management. You need to motivate people to be inquisitive and create an innovation environment. So I'd like to say thank you, and really to say that the achievements of the IAPT program so far are of course not to do with people like me, but it's to do with the extraordinary workforce, many thousands of gifted clinicians who work unbelievably hard to evolve this novel program and continually improve it, assisted by various government organizations. Thank you very much.
Thank you, Sonia and David, for your fascinating presentations. Great examples of use of evidence with politicians, policymakers, and others. Thank you. Two reflections from me. One is from your presentations, the importance of maximizing the opportunity of what we call the policy window, kind of jumping through it when you can. And secondly, the role of persistence. It seems you know, both of you have persisted over many years, which is very inspiring for the rest of us and shows how we just need to keep on carrying on. So thank you for that. And turning now to questions we've had from our audience, the two most popular are actually sort of two sides of the same coin. So I'd like to ask you both to reflect. So one question was, is publication in a high-profile journal important in influencing policymakers? And then the other side of the coin was another audience member asked about how can so-called lower status research, such as the one they're involved in, which is working with service users on pathways for discharge to primary care, how can that kind of research have a bigger impact, presumably because it might not be published in the Lancet, as you were sort of alluding to, Sonia. So Sonia, would you like to start, and then David?
Yeah. I probably said some things when I was presenting that are relevant to this already, but I guess the first thing to say is that I've been involved, I've picked out for you some work I've been involved in that I think has had an influence on policy. Actually, the Mental Health Act stuff, not yet, because so much has happened since that independent review that nothing has yet been implemented since the end of 2018. But I've also been involved in a great deal of research that, as far as I can see, has had no influence on anything very much. So it certainly, and particularly perhaps research with negative findings, perhaps it resulted in some things not happening, but that's a bit harder to gauge, really. But I suppose I think publishing in a good peer-reviewed journal is important. I don't think policy people at NHS England or the DHSC get the Lancet through their doors every week. So while it may attract the attention of peers and it's nice for the research excellence framework, actually, I don't think it really matters to be in the Lancet. I think it does matter when you find, particularly when you find something you think is practically helpful, to actively promote the work you've done. And you can do that by blogging about it yourself, by contacting Mental Health Today, the HSJ, the kind of periodicals that are seen by policymakers that may wish to cover it. I'm an advocate of social media. I think quite a lot of the engagement. So for instance, NHS England at the moment has a group of quite passionately committed mental health policy people who, as far as I can see, spend a great deal of time on Twitter picking up anything they think is valuable there. And I would really suggest going there, and it's a kind of democratic, if sometimes slightly bruising space. It is a place where you can make contact with all sorts of different people, whatever stage you're at in your career. Asking the Mental Health or anyone else to blog about your research. I think you do increase the chances by doing those things, and also by directly contacting people you know to be involved in policy, also people who influence policy who are in the voluntary sector. Having said that, Naomi mentioned the window, and really at any given time, people tend to be working on certain programs or certain priorities, and it's a lot harder to get people interested in other things at those times, is my experience. Hope that helps.
Thank you. And David, your reflections?
Yeah, I would think that publishing in the Lancet is totally irrelevant. I really don't think it's important for you to publish in the most high status things to influence policy. I agree very much with Sonia. People in the Department of Health aren't really looking at that. It is important that the research is good and clear. That's really critical. But then I think it's a matter of explaining it to policymakers in a clear fashion, and also explaining to them how it could be implemented, so that it's not that it's just a good idea, but you have a plan for how it could be effectively implemented. And you can lay out the costs of doing that, because it's always the costs that are relevant in government. So don't sort of say, you know, we'd like you to do this, but I've no idea how much it costs. Please do your own calculations. Because the Treasury will always come out with some impossible calculation and they'll say, no, don't do it. So you have to get involved in doing the cost calculations as well. And then, you know, your pitch is, this would really help people, and this is how much it costs, and you're also going to save an amount. The Treasury can then check your calculations and might moderate them, but you're in the game because you've given that combined argument. There's a question about when is it worthwhile. I don't think big things happen in British public life outside of the period just before and after an election. So certainly with IAPT, we have timed everything to the run up to elections. Because if you want a big commitment, then you ideally want it in a manifesto. And so it wasn't an accident that the first commitment to IAPT was in the 2005 Labour manifesto. All three parties had a commitment to expanding it in the 2010 manifestos, and every party in the UK had a commitment to expanding in the 2015 manifestos. And that was because we lobbied very specifically the people who are writing the manifestos in the run up to it. And why is it important to be in a manifesto? Well, it's because the civil servants feel an obligation to make sure they implement manifesto commitments. But if things get committed mid-parliament, then it's a bit more tricky to do it. And the money hasn't necessarily been set aside. There is, of course, another magic moment, which is when a spending review is being planned, and getting your argument in at that point is really critical. So I think, you know, the argument being not only that this research will really help, but I can show you how to implement it and you can do it economically, and then pitching it in those right windows is key. There was another question, a bit of the question about service user views. In my experience, they are absolutely critical. And certainly if you're talking to politicians, which you'll have noticed is how the IAPT program went, it wasn't lobbying through the Department of Health or the equivalent of NHS England at the time, it was going direct to the politicians. Then I think users are voters, and what users think, in my experience in talking to politicians, is utterly crucial. And so I think bringing a group of users with you and indicating that users would really like this and that they've been involved in some of the design, I think goes an awful long way to implementation. And you know, it's going even more now because NIHR quite rightly puts even more emphasis on user involvement. Sally Davis did exactly the same. So I wouldn't be shy about that. That is really a crucial bit of the research enterprise.
Thank you. And there's another set of questions which really follows on, which is what happens if your evidence doesn't fit with current policies? How would you go about trying to get this evidence taken on board? Sonia.
Well, when I was talking about evidence fitting with policies or not, I guess I meant that evidence that fits with priorities. So for instance, with the things that people have committed to work on in the course of the 10-year NHS plan, or that those are more likely to get in there than things that aren't identified priorities. But yeah, I have been involved in some research that's shown things didn't work that were policy commitments. So for instance, although it's still, I think, somewhat contentious, the assertive outreach teams were a policy initiative that was followed by a randomized controlled trial led by my colleague Helen Gillespie and various other studies suggesting they weren't effective. And I suppose what that seemed to result in was not a sudden reversal of policy, but people sort of keeping on about this finding in various spheres, and when various kind of guidance was subsequently formulated, and they seemed to sort of gradually drop away as a central plank of service provision over time. So I guess all one can perhaps do is to keep drawing people's attention to what doesn't fit. And I mean, in my experience, sometimes it takes 10 years for people to seem to pick up a potentially significant piece of evidence when the time is somehow right.
Thank you. And David?
Well, obviously, research that doesn't fit with current policy is of immense interest because, you know, we're always looking at how to improve things, aren't we? So in principle, it should get a very good hearing. But I think sometimes it doesn't, but there are reasons for that. I mean, one of them is that, you know, if something doesn't fit with current policy, but that's just what it's saying, well, maybe this doesn't work as well as we thought, but there isn't a follow-up practical plan about how we could do something better, then it won't necessarily change policy very much because people won't necessarily know, well, where do we go instead? And also, of course, sometimes you need a fair amount of replication if something doesn't fit with policy because, you know, the policy is a bit like an oil tanker and it takes quite a while to turn it round. I mean, a good example of this, I think, is the literature on psychological debriefing. So psychological debriefing was offered very extensively to people who'd been involved in lots of traumas. It was a very big industry. The first study which showed that actually it didn't help and was harmful, it actually kept PTSD symptoms going longer, which was from our group, didn't change policy. But of course, about 4 or 5 years later, there was a change of policy. And that was really to do with two things. One is that NICE had now seen there were about 6 studies that all showed the same thing. So it felt there was enough evidence for it to say, you know, don't do this. But also in framing that guidance, NICE was very sensible, which also said, but do something else. And what it said was, you know, have watchful waiting for a certain period of time. And then we do have evidence that psychological interventions of a slightly different nature coming in a bit later are very helpful. And so I think, you know, the literature on the first studies on debriefing, even though they showed actually that it was toxic, didn't change policy overnight. It needed that combination of replication and then putting into a recommendation which had a practical alternative suggestion as well. So I think, you know, if your research is something that doesn't fit with policy, think about how you can put those other building blocks in to change things.
Thank you. And another member of the audience has asked for some advice for early career researchers about how they can initiate and build relationships with policymakers. Would one of you like to give some advice?
I guess finding people. So some of the early career researchers I know who work on loneliness, which is something I'm involved with researching, have made some really good links with voluntary sector organisations who are in their sphere of interest and who have valued their input to thinking about questions of evaluation and to things like training, and that has sometimes given early career researchers, I think, more of a voice. I suppose talking to the people, the senior staff you work with, about how you can get involved, about opportunities to come to meetings or the kinds of ways you might get experience of engaging with policymakers. As I've said, social media is quite democratic. That's also a good place to establish yourself, as some early career researchers have. I guess those are some suggestions.
Thank you. David, any other suggestions?
I thought Sonia's suggestions were really very helpful. I mean, I think the main thing I would say is never give up, try and try again, and just reach out to as many people as you have the opportunity to meet at conferences and in other occasions. I think in my experience, it's never the case that you suddenly find some wonderful person in NHS England or the Department of Health who hears the first time you mention something and says, yes, that's great, let's do it. In my experience, you probably find 99 people who are polite and have no interest, And then eventually you get one person who's willing to go for it. And it may not even be the person you are at all thinking about. And you may never know why they went for it. There's a good chance that they have a member of their family or someone who's affected by the same condition and listens more to it. But I think just to that, in terms of the IAPT story, I mean, I did reach out to many people in the Department of Health, as it was in those days, with the plan, and no one went for it over many years. And I think for me, it was just a chance cup of coffee with someone I'd never met before, who's Richard Layard, an economist, while we were at a conference and we were waiting a long time for the coffee queue, something many of us miss nowadays. And we just chatted about what we each did, and it turned out we had a mutual interest in mental health. And we then plotted, well, what different arguments might work and what different approach might we do, and we thought we'd actually sidestep the Department of Health and go straight to the politicians. I'd never have thought of that on my own, but I think because I'd not given up, and he was probably the 100th or 150th person I talked to, you know, it was a possibility. So it's just impossible to predict, but never give up is the key thing.
Serendipity seems to be quite important as well. And thinking about it from the other side, one of our colleagues asked about how well academic institutions encourage product champions such as yourselves with getting research into practice.
I mean, certainly in theory they encourage them, don't they? We have to fill out quite a lot of forms, and when you apply for promotion, and so, you know, it's certainly something that one's told to do, and that I guess things like REF impact assessments encourage. I'm not sure that there's so much help in understanding how to do it or necessarily helping develop pathways. I think there's some of that kind of activity, but certainly that there could be more and more effectively targeted, I guess. I actually found the REF impact case study process really helpful, because it made me go and ask a lot of people whether our research had any impact on their policy, and the results were, unless they were just being nice, the results were really encouraging. So it was quite a positive experience.
Thank you. David, any thoughts?
Well, I'd agree with Sonia that things have improved because of the REF. Certainly for most of my career, the sort of thing to do with the implementation of treatments was seen by my universities as much less interesting than me publishing trials showing that we've got a new treatment that works. As far as they were concerned, that trial was the end point, and if it was in a high status journal, they were even happier. But I think nowadays, universities and employers are much more interested in you trying to make sure that these things have a real benefit to the public, because a lot of the resources in the REF are linked to these impact stories. So that has been very helpful. But the problem with impact stories is it does take a long time to get a good story for the next REF, and most younger people aren't going to manage that. And so I think we still have a lot of work to do to make sure we have the right culture in all of our institutions to encourage people to do more implementation work, even if it's maybe not going to get big enough for certainly a UCL impact story, you know, in the next REF, which is a very high barrier. And I think we are a long way from that. Most universities still put much more credibility on journal articles in high impact journals than they do about someone moving the next step forward to really maximizing public benefit from the research. And I mean, I'm in charge of the REF in Oxford for the impact things. And it's quite hard work encouraging everyone to try and focus on implementation, even now, and not because people aren't sort of interested, but the contingencies, I don't think we've still got them quite right.
Thank you very much, both of you, and for your presentations illustrating the public benefit of each of your research programs. And thank you to our audience for their great questions and your thoughtful responses. That's been a really great plenary. We have to draw to a close now, so I'd like to remind everyone about the next plenary webinar. I hope you'll be able to join us. It's tomorrow morning at 10 o'clock British Summer Time on remaking urgent and emergency care, the contribution of research. So thank you very much for joining us, and I hope you'll join us for the 2 plenaries tomorrow. Goodbye.